blocked tear duct or dacryostenosis this way. We are constantly making tear 24/7, 365 on the surface of our eye. As we make that tear, though, the excess tear drains away from the eye through an opening in the upper and the lower eyelid called the lacrimal punctum. Through the punctum, through a little tube, so to speak, to this what we call the nasolacrimal sac. The nasolacrimal sac will pool the tears, but then they will then drain through the nasolacrimal duct actually into the nose. So I'll kind of describe to moms that when a mom is watching a sad movie and they're crying, they notice that they have a runny nose because now they have excess of tear draining into their nose. I also will describe that we know that the tears drain into the nose because if you ever take an eye drop, put it in your eye, sometimes you'll feel like you can taste it. And the idea being that medicine is mixing in with your tear, draining into your nose and down the back of your throat. So the problem typically is a blockage down around the end of the duct called the valve of Hasner. That valve is stuck shut. And because it's stuck shut, the child makes the tear tries to drain, can't get past that valve, and then everything starts to back up. And as it backs up, it starts to pool on the surface of the eye, and if it continues to pool on the eye, those tears have nowhere else to go than to drip down the face. So inappropriate tearing, otherwise called epiphora, is the hallmark sign of a blocked tear duct. The second sign of a blocked tear duct is the chronic infection that the patients can have. I will kind of describe it this way. If you think of that like a swimming pool, if you fill a swimming pool with water, but you forget to put chlorine in the pool, at some point within a couple days or weeks, that pool is going to start to get full of algae, and it's like the chronic infection that they get. The bacteria that naturally live on our skin will get in there, but because they're not drained away, those bacteria will sit around in that excess tear, and then we'll get a low-grade infection that will seemingly respond to antibiotic, but when we stop the antibiotic, the infection will seem to reoccur, and then and people think that the medicine doesn't work when in fact it does work. It's that the medicine is not affecting the blockage. So these are the signs of chronic, and the chronic infection is called a chronic dacryostenosis. So these are the two symptoms we're going to see until this either gets better on its own or we may have to help it open. I will usually tell families that most patients will clear by around 6 months of age, but every day and every week and every month that the child gets older than 6 months of age, it's becoming less likely they'll get better. And usually by somewhere around 9 or 10 months of age, if the patient has not gotten better, then I will recommend our initial primary treatment for a blocked tear duct, which is called basically a probe. A probe is, when I have to do a probe to open a blocked tear duct, what I usually will do is I will dilate the opening in the lid. I will then stick a probe in the system, advance that probe down through the nasolacrimal duct into the nose, and that usually will open up our tear duct almost 90% of the times. And if I am able to get a patient that's young enough, when I'm able to diagnose this, many times we can perform this procedure actually in the office, and that will eliminate usually the riskiest part of this procedure, and that's going to the hospital or a surgery center and having to do it under general anesthesia.